Ladies and gentlemen, welcome back to the World Implantology Summit 2020, brought to you by the World Dental Council in association with IDC Dental Implants and Antea. Time to introduce our second speaker for today, who is a renowned implantologist from Italy. He completed his dental degree from the University of Turin in 1992. He completed an implantology DUI degree at the University of Aix-Marseille in 2009. He is the clinical director and owner of Tealdo Centri Odontoiatri in Santo Stefano, Belbo, and in Alba, Italy. And he is a lecturer and research advisor at Genoa University. He's here to present a webinar for us on the topic of immediate function in the atrophic maxilla using digital workflow in zygomatic implant therapy. Please give a very warm welcome to Dr. Tiziano Tealdo.
Thank you so much for inviting to me to speak at such a prestigious meeting. I feel very honored to be here with you today. My presentation after introduction will focus on the specific topic of how biomechanical insight and advances are driving surgical and prosthetic protocols in full arch immediate loading rehabilitation with Zygoma implant in atrophy maxilla. Non vedo niente.
Ok, vai sulla presentazione.
Ok.
No, no.
Ok.
Keynote.
E questa. Ok. Okay. Okay. I am living and working in a beautiful area called Lange, and it is a UNESCO World Heritage Site. This is my private clinic in the northwest Italy between Turin and Genoa. At the University of Genoa, Director Professor Pera, in 2003, we developed what we call the Columbus Bridge Protocol. With this protocol, we are able to rehabilitate even most hopeless dental conditions using an immediate bridge delivered within 24 hours from surgery, while maintaining the same level of reliability and the aesthetic of delayed protocol. This presentation will discuss critical factors from no? Non la vedo, no?
Allora, questo era tu. Vedi che prima abbiamo condiviso uno schermo. Ok? Allora,
Ok.
adesso lo facciamo di nuovo partire. Facciamo partire all'inizio, no?
Sì, ok.
Voilà.
Ok. Okay. This presentation will discuss critical factors from workup and pre-treatment planning to important consideration for providing an immediate fixing implant supported restoration. In full arch immediate loading, implant length, cantilever length, framing material, occlusion material play a key role to reach the same implant survival rate as delayed loading. Zygomatic implant have been an evidence-based surgical and prosthetic solution since 1999 and have eliminated the need of bone grafting altogether. Zygomatic implants were first introduced by Professor Brannemark and to prosthetically restore patients with severely extensive maxillary defects caused by oncological resection and by congenital and traumatic malformation. During the last 20 years, Zygoma implants have become a viable alternative to traditional reconstructive technique in the treatment of maxillary atrophies with high post-surgical success rate of 15 years. In this lecture, I'm going to talk about fully arch immediate loading rehabilitations using simplified implant protocols that we call the Columbus-Breeze protocol with a reduced number of implants and reduced treatment time. The Columbus-Breeze approach for the full arch breeze treatment is based on a scientific evidence supported by international medical literature publication. The key main difference that distinguishes the Columbus-Breeze from the other protocols is the use of a cast metal framework or PIC material that we'll discuss later, material for the immediate rehabilitation. According to results of a recent literature, the key points of our protocol are now well supported by publications in international journals. We can have 4 different levels of maxillar bone resorption, and the surgical challenge increases with higher atrophy levels. Aesthetic and biomechanics challenge increases with lower atrophy level. The first case I'm about to present refers to a patient affected with light atrophy condition. And this is ordinary Columbus-Breeze protocol case. And you can see preoperative digital images, X-ray examination, and conical implant, 13 millimeters length, wide diameters during insertion, surgical insertion. A regular platform low profile for a screw retaining prosthesis in place onto fixture level, platform reaching concept in screw retaining prosthesis are applied. In immediate loading procedures, success factors are inertial control are the results of a delicate balance between initial implant stability and loading condition. Because clinical evaluation of implant chromotion is not possible in immediate loading protocols, high implant primary stability is recommended and the control of loading condition is mandatory. After impression, you can see the soft tissue position impression of the implant details. The aesthetic outcome is one of the major requirements for our patients. The rigid splinting is particularly important in the first stages of bone healing in order to avoid the risk of implant micromotion. The most concerned aesthetic area is normally the 80% upper incisor visible in the smile line evaluation. Here you can see the close-up retracted lateral view. The bridge screw retain is in place, and the follow-up about X-ray examination with the long implant taper at the 20 meters and 4 diameters. About the second topic, digital planning workflow. Total face approach is the approach that we use in digital sequences. And digital impression is used in digital planning workflow to plan the aesthetic before the surgical approach. We start with the scanner. This is a chemistry scanner. And the scanner makes impression, digital impression of a dentist arch. In this case, upper and lower together. Together with the facial scanner, we are able to orientate the edentulous arch in a correct three-dimensional way with respect to the face. we are looking the use of facial scanner in order to combine the facial scanner with the digital impression. Aesthetic project using Exocad software with virtual diagnostic waxing. You can consider overbite and overjet in relation to patient profile. And the prosthetic volume of the new three-dimensional over-positioned planning, the correct spatial position in relation to the three-dimensional facial view of the patients obtained with the facial scanner. Using the 3D printer, we obtain also the the surgical guide to use the surgical guide for the correct implant position, and the provisional prosthesis volume saved in STL file to make the provisional after surgery. Virtual planing leads to predictable final aesthetic results, as you can see in the final restoration. The third step is a minimal invasive surgery and optimal primary stability. Maxillary bone resorption over time increase in vertical and horizontal way. You know, the Le classification about the different degree of bone resorption in the maxilla. In order to this, we can divide the two different rehabilitation using zygoma implant. Hybrid zygoma on the left, a quad zygoma on the right. This is an example of hybrid zygoma using only one zygoma implant for left and right side, and 2, 3, or 4 implants in the anterior maxilla. When the residual bone higher is less than 10 millimeters and the thickness less than 4 millimeters, the protocol considers a quad zygoma final solution for the fixed rehabilitation maxilla. We have two different surgical approaches, intrasinus and extrasinus, well described by Aparicio and workers in this paper. And we can, with the conventional CT scan, we achieve a DICOM file, and using an appropriate software, this can be converted into a STL file, which is then printed using a 3D printer. This permits us to study the maxillary anatomy before surgery. First step, maximum anterior posterior spread and cantilever length. Our paper that we published in 2008, the purpose of this study was to compare and analyze via 3D finite element analysis the stresses transmitted to the tilted versus vertical implants and the surrounding peri-implant bone in the maxilla. We developed a research protocol using finite element analysis to describe the stresses transmitted to the alveolar bone by implant. As we can see, in compact bone, the concentration of stress is limited to the cervical area, while in the soft bone, the implant acts as a snow ratchet, spreading the stress through a wider area. Moreover, a more distal emergency of the posterior implants results in a better quadrilateral support and does not require the use of any cantilever. 5 steps: choice, appropriate framework, and occlusion material. The aim of this study that we published in 2017, the aim of this study was to analyze through a three-dimensional finite element analysis, stress distribution on 4 implants supporting a full arch implant supported fixed prosthesis using different prosthetic design. We usually compare the Columbus bridge metal framework to orthopedic external axial fixation devices, splinting of the overloading implants and implant micromotions thanks to a better distribution of the applied load. We can apply the same concept with the Zygoma implant as bone anchorage. The presence of the metal framework on the right, compare no framework on the left, is one of the major differences between the Columbus bridge protocol and the other technique. You can see the stresses transmitted to the implants. Remember, red area means higher stress, blue and green area means less stress. This is von Mises share. Conclusion, this study suggests that the presence of a rigid framework in full arch fixed prosthesis provides a better load distribution that decreases the maximum values of stress at the level of implants, prosthesis, and maxillary bone. Using hybrid Zygoma, we consider that the Zygoma implant must always be cross and stabilized with the anterior implant when exposed intraorally. In FEM analysis about the Zygoma bone, occlusal forces through the Zygoma implants are mainly supported by the Zygoma bone, as there is less than 1 millimeter residual crestal maxillary bone at the implant platform in most cases. During the centric occlusion, the abutment implant connection and the middle portion of the implant are under load. In the presence of bending moment during masticatory forces, the mid portion of the implant is under load. This shows as hybrid solution is a better solution when we have enough bone in the anterior maxilla. Last, the next is the choice appropriate occlusal material. This paper that we publish in 13 is about to the shock absorption capacity of restorative material in dental implant prosthesis. And we have conducted 2 in vitro experiments to measure the chaining load forces transmitted through crowns made of different prosthetic restorative materials onto dental implants. A masticatory robot capable of reproducing the mandibular movements and the forces exerted during chewing was used. The forces transmitted in the simulated peri-implant bone during the robot mastication were analyzed using different occlusive material. The results was that in the using immediate occlusion loading protocol, the use of acrylic resin or composite for the final prosthesis as occlusion material, above all in the provisional prosthesis, is essential and fundamental to reduce the risk of overload prior to obtaining osseointegration. Cleansable and maintainable prosthesis. It's very important to perform the final prosthesis in order for the maintenance over time for the patients. Now, we are going to discuss the presentation of clinical cases about the Zygoma implant. We divided the Zygoma case, monozygoma case, bizygoma, and quadzygoma. in order to different level, different degree of bone resorption. Surgical challenge increases with the higher atrophy levels. And in this case, this woman, 64, patient's request fixed rehabilitation. But the problem is on the left side of maxilla. In the left upper area, there is a horizontal significant atrophy, which doesn't allow any conventional implant protocol. You can see in the red circle, the very, very poor bone for the correct implant position. The alternative is bone graft, but with the Zygoma implant, we can do immediate loading without no graft and immediate restoration. This is very important. In this case, the only scientifically reliable immediate loading protocol applied in the Zygoma implant technique, among the several benefits, we can achieve a high primary stability, essential requirement to the immediate loading protocol, thanks to Zygoma hard bone. And we are supported by literature. The conclusion is the rehabilitation of different degree of atrophy maxilla by means immediate loading fixed implant supported prosthesis, supported also by Zygomatic implant, provided excellent medium-term results. You can see very well in this dissection course, course that explain the technique about Zygoma approach. And the case of the patients with the monozygoma on the left, the scan shows in the left, in this area, very, very poor bone in quality and quantity. And we use, in this case, intrasinus technique, Zygoma implant position. You can see the pictures. And the impression after surgery with this hard material. We use a stone. And at the same time, we treated the mandible with immediate loading too. At 24 hours, we delivered the Columbus Bridge Protocol provisional prosthesis and after integration, 3 months approximately, the final restoration with the fixed prosthesis in the upper monozygoma on the left and the conventional Toronto bridge in the mandible. Another case, but not with only one zygoma, but with 2 zygoma, bizygoma cases. In patients 57 is 1, patient's request fixed rehabilitation. This is a periodontal case, and you can see here the difficult about the correct implant position in the posterior area. The left and the right superior sectors present evident pneumatization of the maxillary sinus, which do not allow a conventional mesiodistal tilted implant positioning according to the Columbus Bridge Protocol conventional. And for this reason, our treatment planning was to place 2 Zygoma implants in the posterior area. You can see the CT scan before surgery and the bone, the upper bone after extraction, the monozygoma surgical phase and the normal conventional implant in the anterior area. Impression immediately after surgery, centric relation in vertical dimension, and you can see the final implant position up before suture, impression, vertical dimension, and 24 hours immediate restoration. Periodontal treatment at the same time in the lower. And you can see the full fascial view with the panorex and the provisional bridge in place. After 3 months, we perform the final prosthesis. You can see the aesthetic try-in in the wax and the mucosa aspect from occlusal view, and the final prosthesis before tightening. Full fascial view with the metal framework and 2 long distal zygoma implant and 2 11.5 anterior conventional implant. About bizygoma case in edentulous patients, similar to the case presented, you can see these patients that edentulous since 1986, and in the lower was treated with the fixed prosthesis, no bone in the posterior area. We use the same approach with the 2 distal zygoma implant in the posterior area, and the immediate holding also using impression with the rigid material, vertical dimension with the healing cap with the wax, and in centric relation. After 24 hours, delivered the final prosthesis. You can see the surgical time and before suture, the provisional in place. You can check with the CT scan the correct implant zygoma position. And after 3 months, the permanent prosthetic aesthetic try-in, you can see the perfect aspect of a mucosa around the zygoma and the conventional implant in the upper. And in the final restoration, the perfect lip support and the fascial view and the detail about the aesthetic intraorally. Panorex with the special PIC material in the upper with the final restoration. About quadzygoma cases, we have these cases of very young women, edentulous since 1996. You can see the before extraction, before during the CT scan exam, the bone volume, no bone at all, no bone at all, and the surgical time. We place 2 zygoma into the right, into the left zygoma bone. 48 hours, we perform the provisional prosthesis with the resorbable suture aesthetic try-in, and the aesthetic, and the aesthetic with the final restoration, with the Organiser, similar teeth, similar face, similar smile. Permanent prosthesis PEC framework is a new material that we are developing with the CAD/CAM technique that we explain later. And this is the final restoration in the upper. And when it's possible to reduce the anterior-posterior cantilever, I suggest to place one implant in anterior maxilla using also quad zygoma. Last case is very interesting case because many times we treat in young patients with the total implant failure. Today, in fact, we often treat denturous patients with the failed implants affected by medium or many times severe atrophy, asking for immediate loading rehabilitation. This is a really challenge. This is a case, women, 52, patients request fixed rehabilitation, denturous maxilla since 2015. Due to total implant treatment failure. This is the implant feedback from 2011, 2015. She received 2 all-on-4, 2 sinus lifting. Total was 4 failed implant surgery. And the results is no bone at all. This is the oral mucosa with the last implant that moved, fiber integrated. And the CT scan that shows as is a code 6 classification because there is only basic bone, not alveolar, completely lost. In fact, you can see no bone at all in the anterior and in posterior area. This is a iatrogeny cause. The first step is to perform the conventional denture in order to study the aesthetic. And before surgery, prosthetic and aesthetic plan has been realized applying conventional teeth according to Gerber's for prosthetic principle. Before 3 days after surgery, the prosthetic phases take place. Then using the prosthetic information before surgery, then the temporary bridge is delivered. You can see the delivery of the bridge with the resolvable suture. And 1 week after surgery, the 3D check after from surgery shows an excellent zygomatic bilateral anchorage that permitted the immediate loading of a screw retaining prosthesis and a progressive improvement of the patient's life. After 3 months, the final restoration procedure for the permanent bridge realization according to the standard protocol, and impression and vertical dimension, centric elevation. You can see the mucosa in the frontal and the occlusal view. And the final restoration, frontal view, and the panorex with the PEC material. Studies on biomechanical reaction of zygomatic implants according to quad zygoma approach suggest, speaking about the framework, use a material with an elasticity module similar to the bone. That's why our choice is mainly orientated to carbon or PEC family framework. You know, about the social life for these patients, It's important to underline that the dentulus is a limitation, verbal and non-verbal communication, decrease the social interaction, limitation in personal relationships, loss of self-image, self-esteem, and social sigma, job opportunity, and other limitation to find a panther. Summarizing before concluding my presentation, the recovery of edentulous patients after previous implant failure is, in the facts, a global success in terms of daily life and the social relations, winning all those limitations above listed generated by an iatrogeny edentulous. You can see the full facial view after treatment, and of course, the challenge about the decrease in social interaction and the limitation of personal relationship is a really challenge, but we win. We win. You can see the social aspect, communication and social interactions. And last clinical case, female, 67, patient's request, fixed rehabilitation, partial edentulous since 2002. You can see the occlusal view of partial edentulous maxilla and the three-dimensional view of residual bone. Orbital planings was quad zygoma. We use new Zygoplus that is smaller, is the apical portion of this implant guarantee high primary stability, also the treatment of the surface for improved integration. Here you can see the surgical device about the implant connection, spines, body, apex, and the surface treatment. A different implant length from 30 to 45 millimeters, 55 millimeters, sorry. And in this beautiful 3D video, you can see the approach from flap, and after the incision, you reflect the flap very carefully, the incision, full flap technique, thickness, and we have is mandatory to reflect in order to evaluate the anatomy about the three-dimensional. We remove the masseter fibers in order to improve the volume of the zygomatic bone. We have to consider the infraorbital nerve position, the periorbital lower floor, and the technique is we use very carefully this approach, minimal invasive, to respect the sinus membrane, and to place in intrasinus the zygoma implant, preparing this slot with a special device, special burr, that doesn't cut the mucosa membrane. You can see the bone, we reach the zygomatic bone in the upper, and then we start with the drilling preparation. And during drilling preparation, we measure the depth, and the last choice is the implant length. In this case, we place implants 45 millimeters length. At the same time, we place the pre-angle abutment in order to our prosthodontic project. This is a 60-degree pre-angle abutment. And after the first implant coronally, we place the second one with the same approach, respecting the sinus membrane. You can see the detail about the zygoma bone and the drilling preparation. Very, very important key success to obtain primary stability, because the success means immediate loading. Immediate loading means osseointegration. Normally, with this technique, we have the emergency material approximately in the canine area, and the posterior abutment is in the molar or bicuspid area. And this, you can see the perfect implant prosthetic design, surgery drive the prosthodontic treatment. We obtain perfect quadrilateral support. Here you can see the mucosa healing after 3 months before the final restoration. And this is the catalog about the Zygoplus implant prosthetic components, different 45, 55 pre-angle with different shoulder height. You can choose depending on the mucosa thickness. This is the aesthetic try-in about these patients before the final restoration. And we, at this moment, prefer, usually in this rehabilitation, we prefer, our choice is for PIC family pecton. This material is fantastic because we can use the CAD/CAM procedure, but this pecton resembling human bone, and this means shock absorbing, metal free, high stability and low weight, biocompatible, tasteless, and no thermal or electrical conductivity. This is biological answer for us is very important for correct frame of choice. You can see the processing and digital milling with the PEC family and digital procedure according to the digital impression at the 0 time before surgery. And these digital milling are performed and consider the prosthetic volume of denture performed before the surgery time. You can see the final restoration in place, upper and lower, with the least support, the patient smiling, and the upper and lower to framework in pecton material with the quad zygoma technique in the upper and the 4 implant conventional in the lower. The final restoration, facial view, lateral view, patient satisfied, and I have interview.
Mi dicevano che non avevo osso, che non potevo fare gli impianti, invece ho risolto il problema, sono molto contenta. È stato un problemino non tanto facile sicuramente, perché non è una passeggiata, comunque adesso sono molto contenta.
È andato tutto bene.
È andato tutto bene, adesso non ho male, niente, mangio, mastico bene.
Tutto fisso, niente che si muove.
Tutto fisso, niente da togliere, sono molto contenta.
Lo rifarebbe?
Sì.
Grazie.
Sono molto contenta.
Lastly, I still wish to report the above publication edited with my working team about how on edentulous patients or patients with a compromised residual teeth, a fixed prosthesis rehabilitation can improve physiologic gastric function. This published for us is very, very important because means that our rehabilitation is not only aesthetic, but improve the functional, improve the quality of life of the patients. This is an example of an 83-year-old woman who, following fixed rehabilitation, has resumed a full physiological recovery, leading an improved quality of life. You can see the zygoma in the posterior, a 4-shore implant in the anterior maxilla, the final restoration, 3 implants in the mandible, very atrophy also mandible, and the final facial view before and after treatment, all fixed upper and lower. So, thank you so much for your attention. No one should die with their teeth in a glass of water, Professor Breimer. Thank you so much to follow me during my presentation.
Thank you very much indeed for a fascinating talk. Dr. Tiziano, we have some questions from the audience, if you would be so kind. Starting with this first question comes from Amrit Kashia, and Amrit would like to ask, why is composite better than amalgam?
Because they guarantee shock absorption during the chewing, during the function, masticatory function, and they reduce the forces applied to the bone, to the interface between implant and bone. This is a study that we publish in International Journal of Prosthodontic in 2003, compared zirconia, ceramic, composite, gold alloy, and acrylic resin. It's better to use acrylic resin in the provisional restoration after 24 hours and use for the permanent prosthesis composite, above all when you have upper and lower rehabilitation of fixed implant, because you don't have any proprioception. It's important, only osteoperception. The problem of this rehabilitation is the chipping, the really problem. But with the composite, we can solve, because the same material upper and lower, and we can reduce the chipping using, according to Professor Jent of Göteborg University, that suggests overbite, overjet, only 1 millimeter horizontal and vertical prosthetic relationship between maxilla and mandible.
Thank you very much. Our next question comes from Nida Fatma. Nida asks, what is the most reliable method for the assessment of osteo integration in a dental implant?
But I think that we have you can use Osteo, but normally in Zygoma implant, we have only osseointegration in the terminal portion of implant. And really, you can use CT scan and the clinical evaluation because really zygomatic implant, normally the length is 40, 35, 50 millimeters, and only 15 millimeters into the bone. The other part is into the sinus and is not integrated because you are a phenomenon that we call bending. It is not the same concept about the normal conventional implant. This is the reason that we use a clinical and CT scan evaluation. And normally the patient doesn't refer pain, doesn't refer symptom during the function. Normally we are sure that our success is completely, our treatment is completely. But I don't have any experience using Osteo for resonance frequency analysis to evaluate osseointegration with Zygoma implant. I know, you can use Osteo for the conventional implant, but I don't know about the use of Osteo for Zygoma implant. The only evaluation is really a clinical evaluation according to what the patients refer.
Thank you very much. Next question comes from Dr. Sajid Hussain, and Dr. Sajid asks, what are the benefits of zygomatic implants, and do they give high primary stability for immediate function?
Really is that many times, as I showed, the patients come to us after failure, after conventional denture, and the possibility to offer zygomatic implant hybrid or quad zygoma with orthopedic splinting, because we are talking not of conventional implant treatment. This is orthopedic treatment, really. And the concept is the splinting, the rigid splinting. And if you achieve high primary stability, if you are sure to have splinting with the fixed prosthesis with not misfit, with the perfect fit, you are sure that you have a rigid situation, orthopedic situation that ensure not only osseointegration, but the maintenance of the stability of osseointegration for a long time. This is the concept, rigid splinting, but also high primary stability. And the zygoma bone normally is similar to the mandible symphysis intraforamina area. When you prepare implant in the intraforamina area according to the conventional Toronto bridge, for example, the consistency of the quality of the bone that you can find in drilling, during the drilling preparation in the zygoma bone, very similar to the anterior mandible. And anterior mandible immediate loading is very, very easy. It's not, is a gold standard. It's not an option. It's really the first choice in our clinic, I think, for everyone.
Thank you. Our next question comes from Deepika Yagatisan, and Deepika asks, is an MRI scan advisable in patients with zygomatic implants?
What about MRI? Is microtech, sorry, MRI. We don't know, we don't use MRI, but normally we do the CT scan after surgery in order to consider the anatomy positioning respect to the orbital 4 in order to obtain the bicortical, because sometimes, as you show in the video, in the 3D video, we perform the cortical zygomatic, of course not below the skin, of course not the skin, but we prepare the cortical bone in order to position the apex of the implant in the external cortical bone. We evaluate with the microtrack or the CT scan the right position in this way. Not too much, because this is a problem for the patients when the patients touch the skin, but not less is a compromise between the primary stability and bicortical positioning.
Thank you. Our next question comes from Hitesh Ranjan, and Hitesh asks, do diabetic patients need any special care before implant placement?
It's a good question. This is a good question because, of course, we have to evaluate the medical aspect. In Italy, we call hemoglobina glicata, cioè the quantity of the average of the glucosio is connected with the hemoglobin. And you have to evaluate the medical aspect before, of course. But is a good question because I use the PRGF in diabetic patients, the platelet derived factors, because it's important. This improve the healing process in diabetic patients, or meaning the patients that the healing process normally they go slowly, and that we use the platelet growth derived factors because it's a membrane that protected the bone and reduce the problem during the first healing phase, and then prevent the mucosa dehiscency. This is very good question. I suggest in diabetic patients I use all the time PRGF or platelet growth derived factor. It's very, very important to ensure the right healing process in the patients, like diabetes patients, in which the healing process normally are compromised. Yeah.
Thank you. Our next question comes from Dr. Maheswari Elumalai, and Dr. Maheswari asks whether smooth, rough surface or any surface modification, which type of surface modified zygomatic implant showed the highest success rate?
Good question, good question, good question, because I show in my presentation the first cases with the Nobel BioCare Zygoma implant. Nobel Zygoma implant in the past started with machine implant with the Professor Brannemark. After 2001, they start with a new surface called, T-Unite. T-Unite is good for improved osseointegration, but the problem is the perimplantitis. Depends, because the Nobel BioCare speaks about the muco-osseointegration, but I think that is a philosophy. It's not easy guarantee muco-integration to the patients, because sometimes we have, in case when you have not intrasinus approach, extrasinus approach with the body of the implant between the mucosa and the cortical lateral bone, we can have the dehiscency. This is a problem. We are following a student at university. We're going to do the thesis about this, and the really problem with the roughness surface, about the not the trade, the portion of the implant inside the bone, but the portion of the implant inside the sinus. The really problem about the roughness surface is the dehiscency and mucosity, and after that, the infection of sinus. In fact, now I prefer to use machine surface, small, and not roughness surface, because in my opinion, we are not sure, above all, if the patient is a smoker or is they not clean very well, to guarantee the perfect mucosa stability around the neck of the implant that connected with the fixed prosthesis. This is a good question, but I think that we have to try, and we have to evaluate with the retrospective study how we have done, and then to stop and to change sometimes approach or technique, because Nobel Biocare speaks about muco integration, but we don't know about muco integration is really or not. Depends, but this is a good question. Sorry, but it's not easy to be clear, but is a problem, the mucosity around the roughness surface. I suggest smooth surface about implant, like the last zygoma that I presented by EDC Italian factory. Okay.
So Dr. Tiziano, thank you very much indeed. That's pretty much all the time we've got for now. So thank you for all those excellent questions. If anyone does have any other questions that they would like to ask Dr. Tiziano, you can see his contact details on the screen there, or indeed you can get in touch via us at membership.worlddentalcouncil@gmail.com. So thank you so much, Dr. Tiziano, for what's been an excellent session. Do join us again tomorrow for our final speaker of the summit, which is renowned implantologist and key opinion leader for the IDC Implants company, Dr. Andrea Alberghini Maltoni. He will be speaking to us at 12 noon tomorrow UK time, so do join us for that. But in the meantime, thank you for joining us for these 2 sessions today, and we look forward to seeing you tomorrow.
Thank you so much, Mr. Andrew.
Thank you.
Bye. Thank you so much. Okay. Finito? Penso di sì.